hand over to Dr. P.C. Manoria. Sir, over to you for your presentation.
No, stroke in atrial fibrillation occurs because of detachment of the clot from the left atrium into the cerebral circulation. And as you have already heard, we have 4 US FDA approved agents, but only 3 agents are available in India. Now, this shows the major achievements of NOACs in our day-to-day practice of prevention of strokes. They decrease hemorrhagic stroke and intracranial bleeding by 50%, and all of us knows Asians are more prone for intracranial bleeding, and once they bleed, they often bleed to death. Strokes are decreased by 19%, and all-cause mortality is decreased by 10%. The same shows in this meta-analysis, but I want to draw your attention that if warfarin had come later than NOACs, what would have happened? Now just see, if VKA had come after NOACs, then when the data of warfarin is to be presented before a professional body, what will it appear like? Stroke or systemic embolism increased by 19% by warfarin, all-cause mortality increased by 10%, ICH increased by 52%, major bleeds increased by 31%, and GI bleed decreased by 25%. I'm sure warfarin would never have been approved, and no professional body would have ever approved this agent for prevention of stroke. So nobody should doubt the superiority of NOACs over VKAs. And we have already seen that warfarin enjoyed uncontested supremacy from 1954 to 2010, but now NOACs are taking over it. And therefore, has time come to say bye-bye to NOACs in non-valvular atrial fibrillation? The HRS APSC 2017 has already done it, and it recommends NOACs as the default choice for prevention of stroke in non-valvular atrial fibrillation. And the ESC guidelines also says if the patient is suitable for both, NOACs should be preferred and not warfarin. The only place where VKs are used is moderate to severe stenosis of the mitral valve and mechanical prosthetic valves. Now let's look at the RCTs. This has been already covered by Dr. Brand, and the message from this RELY trial was that dabigatran 150 milligram is superior to warfarin in terms of reduction of ischemic stroke by 34%, and dabigatran 110 is non-inferior in prevention of strokes. And the second big message from the RELY trial was dabigat 110 milligram decreased major bleeding by 20% for superiority, and dabigat 115 was non-inferior to warfarin in terms of reduction of major bleed. Rocket AF trial, the big message was rivaroxaban showed a numerical decrease in stroke and systemic embolism, but was non-inferior, and it also showed non-inferiority in terms of major bleeding. And apexaban, already you heard, apexaban was superior to warfarin in reduction of stroke and systemic embolism. It was also superior in reducing bleeding by 31%. Now, when we look at the primary efficacy endpoint, you can see dabigatran is more potent than other agent in doses of 150 milligram. And when you look at the bleeding potential, apexaban is the safest. Although all the landmark trials with NOACs have been conducted with different subset of patients, and it is not feasible to compare them, but certain facts have emerged from all these trials. For example, if you have a high ischemic risk and a low bleeding risk, dabigatran may be preferred. If you have a high ischemic risk and a high bleeding risk, apexaban is preferable. The second choice is dabigatran. If you have poor renal function, apexaban is obviously the choice. In a non-compliant patient, rivaroxaban may be preferred because it is once daily. And elderly patients who are prone for renal dysfunction, GI bleed, IECH, apexaban is the choice. For patients with GI bleed, again, apexaban is the choice. And for valvular heart disease and prosthetic mechanical valves, warfarin. And CAD and MI, rivaroxaban has shown decrease in MI by 19%. So it may be preferred, although this is a numerical change. Now, what about the data of NOACs in real world scenario? All of us know RCTs provide evidence on safety and efficacy on intervention. The real world evidence is the product of data collected through observation during current clinical practice, and real world evidence can complement evidence from RCT by assessing the wide range of outcomes that are representative of everyday clinical setting. And this is the famous Aristophane trials, which is an observational study over 4 lakh patients, which I will be discussing. As you can see, this large observational study had 4 lakh patients, apexaban about 1 lakh, dabigatran 37,000, rivaroxaban 1.5 lakhs, and warfarin 1.67, and all combinations were tried in this study: apexaban versus warfarin, dabigatran versus warfarin, rivaroxaban versus warfarin, apexaban versus dabigatran, apexaban versus rivaroxaban, and dabigatran versus rivaroxaban. And to reduce the possible bias associated with the confounding variables in the observational study, a method of propensity score matching is utilized. Propensity score matching is a statistical approach to construct matched samples of treatment controls pairs to minimize the difference between the 2 groups. And this shows the upper one you can see is a randomized sample, and the lower one we have taken matched subjects so that they can be compared. Now, this is the baseline characteristics of the Aristophane study. You can see age, most of them are above 75. Males roughly constitutes about 50%. And this is a population which has high CHAD score, 3.9, 3.5, and a has-blood score, which was also higher, unlike the randomized controlled trials, where Rely trial has a CHAD score of 2.1 and Aristotle also 2.1, but the CHAD score was higher in the rivaroxaban trial. CHF was present in about 28%, diabetes mellitus 35%, renal disease 23 to 25%, stroke and systemic embolism 12% or 10%, peripheral artery disease 19 to 20%, coronary artery disease 44 to 45%, and both the lower and higher dose were tried. So unlike the RCTs, this observational study enrolled patients with high ischemic and bleeding risk and had subsets of high-risk patients. Now, when we compare apexaban with warfarin in this real-world scenario, you can see all the hazard ratios are to the left, whether it is stroke or systemic embolism, whether ischemic stroke, hemorrhagic stroke, or systemic embolism, major bleed, GI bleed, ICH, or other bleedings, apexaban is the clear winner over warfarin. Now, when we compare dabigatran with warfarin, you can see compared with warfarin, dabigatran was associated with lower rates of stroke and systemic embolism, hemorrhagic stroke, major bleeding, ICH, and other bleeding. But unlike warfarin, it was non-inferior in terms of reduction of ischemic strokes. And when we compare rivaroxaban with warfarin, you can see compared with warfarin, rivaroxaban was associated with lower rates of stroke or systemic embolism, ischemic stroke, hemorrhagic stroke, and ICH, but higher rates of major bleeding. You can see most of the major bleedings are higher with rivaroxaban. And when we compare NOAC versus NOAC, let's see what is the result. Now, compared with dabigatran, apexaban was associated with lower rates of stroke and systemic embolism and major bleeding and GI bleed. So apexaban is a winner over dabigatran. And when we consider rivaroxaban and apexaban, apexaban was associated with lower rates of stroke and systemic embolism, major bleeding. So again, as you can see, all the hazard ratios are to the left. Apexaban is a winner over rivaroxaban. And when we compare rivaroxaban with dabigatran, dabigatran was associated with similar rate of stroke and systemic embolism and a lower rate of major bleeding. Now, this observational study had standard and lower dose of NOACs, which were studied in the following subgroups: elderly patients, male, CHAD score which was higher, higher has blood score, congestive heart failure, coronary artery disease, peripheral arterial disease, diabetes mellitus, renal disease, and prior history of stroke and systemic embolism. Now, this is a subgroup analysis and shows the hazard ratios of stroke and systemic embolism in NOAC and warfarin propensity score made subgroups according to the age, gender, and the Chatsworth score. And you can see the results of the subgroup analysis on age, strata, gender, and baseline Chatsworth score were generally same with all the NOACs, but the magnitude of stroke and systemic embolism risk reduction for apexaban versus warfarin was greater in females, as you can see, those with higher baseline Chatsworth score. Now, this shows the subgroup analysis of the hazard ratios for major bleeding in NOAC, warfarin propensity score match subgroups according to the age, gender, and the Chatsworth score. And you can see when we look at these comparisons in terms of major bleeding, there was a significant interaction for each NOAC versus warfarin across age, gender, and Chatsworth score, with lower hazard ratio observed in many patients who were younger, were male, and had lower baseline Chatsworth score. Now, when we look at the hazard ratios of stroke and systemic embolism in NOAC warfarin propensity score made subgroups according to the renal disease, which is not uncommon, diabetes, which is not uncommon, prior stroke and systemic embolism, and lower and standard dose, you can see the results of this subgroup analysis on renal disease, diabetes, and prior stroke were generally consistent with the main results in terms of stroke and systemic embolism, and apexaban comparatively numerically better results in patients with or without renal disease, with or without diabetes, and with and without prior stroke or systemic embolism, and also in the lower dose. And when we look at the subgroup analysis of the major bleeding, the result of subgroup analysis on renal disease, diabetes, and prior stroke or systemic embolism were generally consistent with the main results in terms of major bleeding. Apexaban numerically showed better results other than NOACs in patients with or without renal disease, with or without diabetes, and with or without stroke, and with lower dose also. Now, Dr. Brian Pinto has already discussed in detail regarding NOACs in chronic kidney disease. Now, because warfarin is not excreted to the kidneys, it was thought that this would be a better choice for patients with CKD, but now we have a very interesting data emerging from the Canadian controlled study over 2 lakh patients, and this shows there's no reduction in stroke and 44% increase in the major bleeding. So warfarin, which was believed to be the agent of choice in CKD, it has both of the worst outcomes, and apexaban is preferred as told by Dr. Now, another interesting data is emerging up that when we look at the renal function decline in patients with atrial fibrillation OHC, the DOACs are associated with lower risk of adverse renal outcome than warfarin in the long run, as you can see on this slide, whether we talk of the declining GFR, we talk of doubling of the serum creatinine, or we talk of acute kidney injury or kidney failure, NOAC score over warfarin. Now, this is a sensitivity analysis, and which showed compared with warfarin, the mortality was lower with all NOACs, but was least with apexaban compared to dabigatran or rivaroxaban. Now, very interesting data is emerging on inhibition of atherosclerosis progression from the European Society of Cardiology. And as you can see on this slide, it shows that NOACs are associated with significant inhibition of atherosclerosis compared to VKAs. So this is another advantage from the NOAC side. Now, mitral stenosis, tight mitral stenosis, mechanical prosthetic valves are at the present state of time absolute contraindications to use of NOAC. They are class 3 recommendations, but now trials are emerging even in patients of mitral stenosis. The RISE trial in mitral stenosis with the rivaroxaban. We have also trials of dabigatran, which have been initiated with dabigatran, and it would be very interesting to see what does these trials show. And in patients with prosthetic valve, again, at the present state of time, NOACs are absolutely contraindicated after the REALIGN trial, but we know that in the post-operative period, there's a different scenario, intense inflammation, there's activated platelets, circulating procoagulant tissue factor, it is gut dysfunction, the drug may not be absorbed properly, and the dose which was used with this realigned trial was the dose of atrial fibrillation, and therefore it has been debated that this may not be the appropriate dose. And all of us know one of the major problems with mechanical valves, which are highly durable, is the hemorrhagic complications. So if we are able to get a trial which shows positive results, it indeed will be a great achievement. But as already said, mitral stenosis, tight, and prosthetic valves at the present state are absolute contraindications, but trials are being initiated to see whether NOACs could be used in these patients, but only future will tell what is the reality. So the Aristophane trials showed that in this largest known observational study of NOACs used today, this study showed that NOACs were associated with lower rates of stroke and systemic embolism and variable comparative rates of major bleeding versus warfarin. And in addition, a comprehensive set subgroup analysis provided further evidence of important difference among subgroups of patients with non-valvular atrial fibrillation. Now, if we look at the comparison of VKAs with NOACs, therapeutic range, you can very clearly see with NOACs, it is a wide therapeutic range. The onset and offset are slow with VKAs, but fast, so we prefer NOACs. Foot interaction, lot of interaction with VKAs, but there are no interactions with the NOACs, so we prefer NOACs. Drug interaction, VKAs interact with almost many drugs, but drug interactions are much less with NOACs, so we prefer NOACs. Monitoring, frequent INR is required, but with NOACs, no monitoring is required except under certain special circumstances. The pharmacokinetics are predictable with NOACs, but they are not predictable VKAs, so again, we prefer NOACs. Stable anticoagulation is less common with VKAs, but often we have stable coagulation, so again, we prefer DOACs. ICH is more common and invariably fatal with VKAs, but it is decreased by 50%, and therefore, again, NOACs have an edge. Genetic polymorphism can occur with VKAs, but is not seen with NOACs. So again, this is a favorable point. User-friendly, VKAs are not user-friendly, but NOACs are user-friendly. So again, interference with the quality of life, VKA interferes with the quality of life, but NOACs do not interfere. Reversal agent, although we say VKAs has a reversal agent vitamin K, but even if you give vitamin K intravenously, it takes 12 to 24 hours, and even patients with severe bleed with VKAs, we have to resort to PCC or recombinant factor 7A, but the reversal agent, say, of dabigatran is very rapid. Adnexate alpha, which is a reversal agent for factor 10A, is not available in the country. Use in CKD, VKAs are now no longer considered safe, although they are not exceeding the kidney. Apexaban is the agent of choice. And utility in PCI plus AFib, we use one antiplatelet and one NOAC over VKAs, so that is another advantage. And the data is upcoming that inhibition of atherosclerosis is there with NOACs and not with vitamin K, so that is another advantage. And the declining in renal function is also less with the NOACs. So if DOACs would have come earlier than warfarin, I'm sure warfarin would never have been approved because of so many advantages. I'm sorry for the spelling mistake of wood. So the take-home message is DOACs are in, it is commonly called DOACs, but NOACs being a favorite term in old term, we often call NOACs are in and VKs are out. And VKs era in non-valvular atrial fibrillation is becoming a history. The only place left at the present state of time for VKs is more tight mitral stenosis and mechanical prosthetic valve. Thank you very much for your kind attention.
Thank you so much, Dr. P.C. Manoria. I think this was an excellent presentation, and the way you have taken into the in-depth about the NOACs and vis-a-vis the VKs I think is well appreciated by us. So thank you so much to Dr. Brian Peter and Dr. P.C. Manoria. We will now be taking few of the questions which has come from our elite panels who have joined this meeting. So the first question is from Dr. Pankaj. He's asking, doctor is asking, between dabigatran 150 milligram and apixaban 5 milligram, which is more efficacious in reducing stroke and systemic embolism? Over to you, Dr. Brian Pinto, and then we can take the views of Dr. Manoria as well.
If you were to look at reduction of stroke, basically, dabigatran 150 milligrams has proven to be the most efficacious to reduce stroke. There's no question about it. But very close to it is apixaban 5 milligrams. However, if you were to take net safety, net efficacy and safety, then apixaban 5 milligram would be a better choice. But on the data, if you look at the slide that we presented, the data with dabigatran 150 milligrams is superior to warfarin, whereas all other data shows that they are equal or slightly better.
Thank you so much, Dr. Pinto. Dr. Manoria, from your end?
I agree with Dr. Brian Pinto, but in subsets who have a high bleeding risk, we may prefer apixaban over dabigatran if the bleeding risk is very high, chest score is very high, elderly patients, severe CKDs, past history of bleeding elsewhere, so that may be preferred. But it's true that the efficacy-wise, the dabigatran 150 is superior, but the net clinical benefit may become very important in certain subset of patients.
Right. Thank you so much, Doctor. We have one question from Dr. Bhupen Desai. In CVA, no antiplatelet even if patient has atherosclerotic carotid plaque? So,
yeah, I want to answer that question. A very good question. I think if you look at this, when you are giving a patient the anticoagulant, then the data clearly shows that the anticoagulant is sufficient in the situation of a carotid plaque as well, because your chances of bleeding will go up significantly. However, if you have had multiple episodes, then you may consider a single antiplatelet drug, and that antiplatelet drug should not be aspirin. It can be clopidogrel. It cannot be aspirin because with aspirin, bleeding has shown to be much more. Even in patients who have been stented, we have seen that after 6 months to 1 year's time, we remove all the antiplatelet drugs. We only continue with the anticoagulant, except in patients who are at the highest risk. Then we may continue we have to continue the anticoagulant, but we will not continue the antiplatelet. So I think there is a room for Dr. Bhupen Desai to say that a single antiplatelet may be used along with an anticoagulant in patients who have got this particular kind of condition. And we are possibly talking in a situation of atrial fibrillation, I presume, because the topic is atrial fibrillation. So in the subset of atrial fibrillation, we have to use an anti. And then are we going to use 2 antiplatelet drugs? No, we may use a single antiplatelet drug.
Thank you so much. Thank you so much. Yes.
One of the problem which we face sometimes is our patient is on dabigatran 150 milligram twice daily. He's a compliant patient. He develops an ischemic stroke as verified by a CT scan. The EPTT is more than 50, clearly indicating the patient is a compliant patient. Now, under such circumstances, because although dabigatran is superior than warfarin, but stroke can still occur even on optimum dosage of dabigatran. So under such circumstances, what we do is we ask our radiologist to see whether the stroke which the patient has developed in embolic stores in atherothrombotic state. Because elderly patient with atrial fibrillation on occasions, you can also have an atherosclerotic stroke superimposed on patient with atrial fibrillation. And under such circumstances, if it is an atherothrombotic stroke in a patient who is already on dabigatran, we would like to add clopidogrel as told by Dr. Brian Pinto. But if it is a cardioembolic stroke, we may have an option of a left atrial appendage closure device if it is occurring on optimum dosage of dabigatran.
Thank you, sir. Thank you, Dr. Bhupen Desai, for such an interesting question. We have another question from Dr. Pankaj. In LV apical clot, which anticoagulant should be preferred, NOACs or VKA?
See, the basic data is with VKA. So actually for LV thrombus, we prefer VKA. But I want to say that myself and a few colleagues of us have some data with the oral NOACs. We have some data with the NOACs, which shows that in case you cannot use VKA for some reason or the other, the NOACs, though there is no available outside data, the NOACs can be utilized off-label. But this is an off-label use of the NOAC. This is not an on-label use of the NOAC. So if you have an LV thrombus, the on-label use is VKA. But in case there is some reason where you cannot use a VKA, and we have followed these patients up for 6 weeks, 8 weeks, 12 weeks, and we have seen the disappearance of the LV clot even on patients who are put on VKA. So maybe this is an area for study. This can be one of the studies that can be taken up. Warfarin versus VKA in LV clot can be a big study.
A recent observational study showed that warfarin was superior in terms of LV clot compared to.
But that's not a big study, so I think it will need a study. So I said VKA first, but in patients who cannot take VKA for some reason, then you should not give them nothing. You should give them NOAC.
Thank you so much, doctor. So one question is that if the patient's Chadbath score and hazard rate is high, which NOAC will you choose?
I think Dr. Manoria can take that because
Apexaban would see here. We would like to have the net clinical benefit, and obviously Apexaban would be a better choice.
Yes, I agree. I agree.
And such a scenario is commonly seen in
I think this is the common scenario seen in many of our AFib patients, and therefore Apexaban is possibly becoming the number one, or it has already become the number one NOAC, because the net clinical benefit is superb with Apexaban, bleeding being so much less. And also the only one issue I have is that many physicians are using it in the reduced dose when they are not taking all the 3 criteria. Then I think you must use it in the correct dose and not expect the next net clinical benefit to be as good if you use it in a reduced dose.
Correct. Thank you so much, doctor. So there's one question which is there is that patient is on one of the NOAC and have an elective surgery. When shall the NOAC be stopped and then started and then continued?
Does Dr. Manoria want to take it?
Please, from your end.
The rough formula is if the patient has mild or moderate bleeding risk, you can stop for 2 to 3 half-lives, half-life being 12 hours. If the patient is high bleeding risk, you have to stop for 5 half-lives. So that is the rough. And if again the bleeding risk is mild or moderate, you can start after 48 to 72 hours. If the bleeding risk is high, you can start after 72 hours or even more. And you must assess renal function individually, because renal failure is a very important cause of bleeding. So that is the rough.
I think you're right, Dr. Manoria. Creatinine, the GFR is an important thing, creatinine clearance of GFR, because if the renal dysfunction is there, then you have to stop for a longer period of time. And if the renal dysfunction is not there, then you have to stop for a lesser period of time. But Apexaban being cleared by the liver also need not be stopped. But in case of dabigatran, certainly if the renal dysfunction is there, you have to stop it almost for 3 to 4 days before you can this thing. And therefore, the difference is different in different cases. Yeah.
So there is one interesting question on the recent times. Is there any guidelines in the use of NOACs in COVID patients? Is there any recent guidelines or any data you have?
I can only give you the data from Mount Sinai. Okay, there is a very good data which has come out from Mount Sinai, which is a data that if your patient is a COVID patient, you should put him on anticoagulant, especially if there is some evidence that thrombosis is going on. But by that, you will be checking the D dimer of the patient, and even those with moderate COVID may be given doses of enoxaparin, or if they have severe COVID, you can even use unfractionated heparin in these patients, because lots of the patients have complications because of thrombosis and because of emboli also coming about. As you know, there's an ongoing stroke that has increased, ongoing myocardial infarction that has increased. And the recommendation now is that when you're sending them home, you put them on 2 to 4 weeks of a NOAC. The first choice being Apexaban and the second choice being rivaroxaban, so that you will reduce the thrombotic events that will occur in these patients. And this has appeared in the Mount Sinai protocol for treatment of COVID patients. It's a very good kind of protocol that they have given. Heparin, use of enoxaparin, followed by the use of NOAC.
Thank you so much, Doctor. I think there was great answers to all the questions. So I'll request the doctors. I think we have got very good questions. If there are any more questions, kindly put it.
Dr. Brian, I like to.
Yeah.
Sometimes,
Yes,
Dr. Brian, Dr. Brian, sometimes we see patients of atrial fibrillation who are already on a NOAC. They develop ischemic stroke. If facility for intervention is not available, so under such circumstances, if the anticoagulant is still sufficient, suppose INR is 2 or so, then can we neutralize if the patient is on dabigatran with antidote and then do the literature? Any experience?
We have done it in number of patients. Actually, what we do is we give this patient, if basically we look at the PTT for dabigatran, we don't look at the INR, we look at the PTT. So if the PTT is more than 80 as if at the trough, and if the dose has been given very early and then the ischemic stroke has occurred, you can give these patients idarosuzumab. It's available in 2 vials, totally 2.5 milligram each. So you give 5 milligram over a period of about 5 minutes. The action is very fast because this is a monoclonal antibody. It grabs onto the dabigatran very quickly, neutralizes it. And so if you have to take the patient up, then either for a catheterization procedure and give him intracranial thrombolytic therapy, you can do that. Or even if you have to give him IV thrombolytic therapy, if you don't have a cath lab, you can do that if you have neutralized the patient. The facility to do a procedure and give a smaller dose of the thrombolytic therapy would be much safer compared to giving it IV. The other area where you can do this is when a patient has to go for a major emergency surgery. For example, he develops an acute abdomen, or the patient develops a neurological problem, spine surgery is needed, or some kind of brain surgery is needed. Then you can immediately, for example, an aunt of mine had a fall, and we had to, she was on dabigatran. So we gave her idarosuzumab, and she stabilized. But if she had not stabilized, we could have taken her up for the surgery also. She had developed a subdural, but it did not increase because we gave the idarosuzumab very quickly and the patient reversed. So reversal agents are also very, very important for the treatment of something. It does not happen all the time, but when it happens, it's an emergency and has to be tackled quickly.
Thank you.
So thank you so much, Doctor. And so we do not have any more questions as of now. So
you can stop.
Yeah, absolutely, sir. So thank you so much. Concluding remarks from Dr. Brian Pinto and Dr. PC Manoria, please, and then we can close this session, sir.
I think, NOACs are one of the stellar molecules that have come to this era of therapy, especially for atrial fibrillation. One thing that has always given me trouble with warfarin, I would say more than one thing. One thing has been the food to drug interaction, because Valentino Fuster told me that if you are taking warfarin, you should be eating the same food every day. You should be eating the same pasta or the same sandwich every day. You cannot actually enjoy an Indian meal because it contains so many green vegetables, green this, green that, the other. So warfarin, you cannot take any alcohol by and large with warfarin. It will affect, in fact, one patient of mine, I gave him, he used to drink half a bottle of wine every day. So I gave him a meter to check before he took alcohol. On some days when he took alcohol, he did not take his tablet of warfarin. So this was the difficulty, but that was a patient who could afford. So alcohol is no, so foods are no. So warfarin very dangerous. Secondly, warfarin has a tremendously bad effect as far as intracranial hemorrhage is concerned. So many patients we have seen in the years who develop intracranial and major bleeding, and the bleeding with warfarin is much worse than the bleeding with NOAC. Thirdly, the NOAC does not have much drug-to-drug interaction also. You can utilize most of the NOACs without much drug-to-drug interaction. There are very few and you can really memorize them. It's not like warfarin. Warfarin is drug-to-drug interaction. You have to keep the sheet ready with you. And lastly, even if you do your best, the time in therapeutic range is usually less than 60%. In most of the studies, it was less than 60%. And in spite of that, even in the normal range, bleeding was such a large problem. So my opinion, and renal failure, diabetic patients, all that, NOACs have made a big difference. And I agree with the guidelines committee then the first drug should be a NOAC and warfarin only used for those patients who are contraindicated at this point in time, which may also change with time. And warfarin should actually be buried only to be utilized in some group of patients where it is proven up to now it is superior. For example, mechanical valve, where I think the large dose with dabigatran 220 milligram also did not work. It did not work against warfarin. So we have to have certain areas where warfarin is still king, and those areas we should reserve still for warfarin. Otherwise, patients should receive NOAC therapy.
Thank you so much, sir, for your enlightenment. And so, Dr. P.C. Manoria, your comments about your
NOACs have greatly simplified the lives of patients who are on warfarin, and we have saying bye-bye to warfarin in subset of patients of non-valvular atrial fibrillation. They are only used in the 2 remaining subsets. What I like to say you that you must also promote these agents in VTE, which is highly under-recognized, highly under-treated, and VTE is many times missed. So you should also promote these agents, particularly among the orthopedicians, because many times we get patients of pulmonary embolism from the orthopedic side. They have not used prophylactically these NOACs, which should be used in knee replacement and hip replacement. So I think that area should also be covered in subsequently.
Thank you so much, Dr. P.C. Manoria and Dr. Brian Pinto. I think thank you so much for coming to this platform. It was an excellent presentation from both of you, and we really are very obliged. And I would like to also take this opportunity to thank all the doctors who have taken the time from their busy schedule and joined. And I hope this talk from Dr. Brian Pinto and P.C. Manoria has really enlightened each of us. Thank you so much, Doctor.